Hello and welcome to the North Carolina Association of Pharmacists webinar series. We appreciate your participation in this presentation, 2019 Updates in Pharmacotherapy for Diabetes. I'm Dawn Batiste and I'm an Associate Professor of Pharmacy with Wingate University School of Pharmacy. I practice in a family medicine clinic in Harrisburg, North Carolina, primarily providing diabetes management services to adult patients with type 2. I'm joined today by Jackie Olin, Professor of Pharmacy at Wingate University School of Pharmacy. Dr. Olin practices internal medicine at Novant Presbyterian Medical Center in Charlotte, North Carolina. Additionally, Dr. Olin is a certified diabetes educator. Today, neither Dr. Olin or myself have any relevant financial or other disclosures to make regarding this presentation. Our objectives today are for learners to be able to identify changes to the American Diabetes Association and American Association of Clinical Endocrinologists, American College of Endocrinologists guidelines for managing type 2 diabetes in adults. You should be able to describe opportunities to improve diabetes care in older adults, develop an appropriate plan for glucose self-monitoring based on patient-specific factors, discuss benefits and limitations of the sodium glucose cotransporter 2, or SGLT2 inhibitors, interpret recommendations regarding the use of aspirin in individuals with diabetes, and throughout, when given patient case scenarios, formulate an evidence-based treatment plan. With those treatment plans in mind, we're going to start off by taking a look at Mr. A.B. A.B. is a 73-year-old male with type 2 diabetes, hypertension, and heart failure. He did experience a myocardial infarction 10 years ago, and among his current medications, he is taking metformin and glyburide. A.B. reports that he is mostly adherent to his medications and has even lost 5 pounds intentionally over the past few months. However, his A1C remains at 9%. All other laboratory values are within normal limits. So keep Mr. A.B. in mind as we go through our discussion, and we'll come back and see if we can optimize his treatment plan. First, we'll begin with the diabetes guideline updates. In 2018, the ADA, or American Diabetes Association, shifted from a once-a-year publication to a living document that allows for continuous updates as significant new information becomes available. Since the initial 2019 publication, there have already been updates in March, April, and June. This demonstrates the rapid pace of change in diabetes management and the necessity of remaining up to date with the literature. There are a number of modifications in the 2019 guidelines to various sections which can be found in the full guidelines or the abridged standards of care for primary care providers. However, we will focus on 3 sections: diabetes technology, pharmacologic approaches, and care of older adults. Of those, diabetes technology is a new section that has been added to address the growing technology options and the potential benefit of these tools in diabetes management. Currently, insulin delivery and glucose monitoring are included. However, in coming years, this will be expanded to additional issues such as medical devices, cost and privacy, telemedicine, and more. We will discuss glucose monitoring later in this presentation. Our primary focus on ADA updates are the pharmacologic approaches. This has undergone significant change to align with the ADA and European Association for the Study of Diabetes consensus report that was published in 2018. This is the algorithm that many of us think of from 2018, in which metformin is initiated and further treatment is primarily based on A1C and a history of ASCVD in addition to patient-specific factors. However, as you can see, the algorithm has undergone major changes. Some pieces remain the same. Comprehensive lifestyle management is necessary for every patient, and metformin remains first-line treatment unless contraindicated. Also, for those with an A1C greater than 10%, blood glucose greater than 300, or significant symptoms, insulin may be initiated at diagnosis. This can be done in combination with a GLP-1 agonist. However, beyond this initial therapy, typically with metformin, add-on therapy is now determined by multiple factors. I do want to point out that this figure was first published in January 2019, and the ADA has since issued additional updates in the living document that are not reflected in this image. Now let's take a closer look. After metformin, the first step is to evaluate for a history of ASCVD, or atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease, CKD. ASCVD include acute coronary syndromes, myocardial infarction, stable or unstable angina, stroke, transient ischemic attack, peripheral artery disease, aortic aneurysm, or coronary and other revascularization. In the case of a patient with a history of ASCVD, a GLP-1 receptor agonist, or SGLT2 inhibitor, with proven cardiovascular disease benefits is preferred. According to the ADA, proven benefit is defined by a FDA label indication. Currently, this includes liraglutide, empagliflozin, and canagliflozin, although the ADA notes modestly stronger evidence for empagliflozin over canagliflozin. It is pertinent to note additional agents have positive CV outcomes without a current label update. Summaries of this additional information can be found in Table 10.2 of the guidelines if you're interested in additional detail. At the time of this presentation, the most recent cardiovascular outcome trial, REWIND, was not yet incorporated into the ADA guidelines. REWIND compared the use of dulaglutide to placebo in addition to standard of care. Dulaglutide provided a 12% reduction in the primary composite endpoint of non-fatal MI, non-fatal stroke, and death from cardiovascular or unknown causes. This was a statistically significant difference when compared to placebo. The median follow-up for patients was approximately 5 years. Unlike previous trials, this was generally a lower risk population, with only about 1/3 having previous cardiovascular disease. This raises the question if GLP-1 agonists may have cardiovascular benefit even in patients who do not have previously established ASCVD. It is prudent to monitor for additional updates to the living document now that this data is available. On the other hand, in patients in whom heart failure or CKD predominates, a SGLT2 inhibitor with proven benefit to reduce heart failure hospitalizations and/or CKD progression is recommended if GFR is adequate. Since the initial publication of this figure, the DECLARE-TIMI 58 trial was published, which demonstrated dapagliflozin was associated with reductions in heart failure hospitalizations and renal events. Based on this, the ADA now states empagliflozin, canagliflozin, and dapagliflozin have all shown reduction in heart failure and reduction in CKD progression, so any of the 3 agents are reasonable. If the SGLT2 inhibitor cannot be used in this patient population, a GLP-1 agonist with cardiovascular benefit is once again suggested. In each disease state, additional agents may be added as needed to reach glycemic targets. Special considerations include not adding a DPP4 inhibitor to a GLP-1 agonist due to limited added benefit with the similar mechanism of action. Additionally, the DPP4 inhibitor saxagliptin should be avoided in heart failure because, although evidence is conflicting, some data has shown an associated increased risk of heart failure hospitalizations. If a patient does not have a history of ASCVD, heart failure, or CKD, additional factors may be considered, including hypoglycemia, impact on weight, and cost. For those with a compelling need to minimize hypoglycemia, DPP4 inhibitors, GLP-1 agonists, SGLT2 inhibitors, or TZDs may be utilized. Weight gain can be mitigated using a GLP-1 agonist or SGLT2 inhibitor. Specifically, of the GLP-1 agonists, semaglutide has the greatest impact on weight reduction, followed by liraglutide, dulaglutide, exenatide, and finally lixisenatide. No differentiation is made between SGLT2 inhibitors regarding weight loss. In situations where cost is the primary barrier, sulfonylureas or TZDs may be considered. As you can see, there is overlap between groups of preferred agents, so a patient-centered approach should be used. For example, a SGLT2 inhibitor may be beneficial in reducing CKD progression and mitigating weight gain while minimizing hypoglycemia risk. However, cost may be a concern for some patients. For refreshers on medication class-specific information, you may refer to Table 9.1 in the ADA guidelines. The American Association of Clinical Endocrinologists and American College of Endocrinology, or ACE algorithm, remains very similar to what we have seen before. As always, lifestyle optimization is critical for all patients. Additionally, they highlight that minimizing hypoglycemia and weight gain are of the utmost importance. Initial pharmacologic treatment is recommended based on entry A1C. For those with an A1C greater than 9% and symptoms, insulin initiation may be appropriate. For all others, non-insulin therapy should be started. The list of medications in each column is in order of recommended usage. The length of the green line beneath the drug class indicates the strength of the recommendation. As seen with the ADA, metformin is the preferred first-line agent. Since 2018, the strength of recommendation for GLP-1 agonists and SGLT2 inhibitors have increased. One of these classes should be included if coronary heart disease is present. In a patient with a history of cardiovascular disease or chronic kidney disease, an agent with proven benefit should be used. Unlike the ADA, this particular consensus statement does not indicate preference for particular agents within a class. Instead, the overall manuscript outlines the available evidence and reports FDA indications as of December 2018. Like the ADA, the ACE consensus statement also has a table to briefly review profiles of various therapies. Here they note that liraglutide is FDA approved to prevent major adverse cardiovascular events. Empagliflozin is approved to reduce cardiovascular mortality, and canagliflozin is approved to reduce major adverse cardiovascular events. They also note that saxagliptin may increase the risk of heart failure hospitalizations. Unlike the ADA, the ACE also notes the same potential heart failure hospitalization risk with alogliptin. Regardless of the order of preference indicated by the previous slides, all treatment plans should be individualized based on patient-specific factors. Overall, we need to remember lifestyle modifications and metformin remain first-line therapy. However, we need to become more intentional in consistently evaluating patients with type 2 diabetes for a history of ASCVD, heart failure, or CKD prior to adding therapy so that agents with proven benefit may be considered. Again, ultimately, patient-specific factors must be considered. Now we'll transition to taking a closer look at improving diabetes care in older adults. Pharmacists can have a role in identifying older patients that could benefit from medication optimization. The ADA continues to have a specific section dedicated to the treatment of older adults. They note that overtreatment, defined as tight glycemic control in individuals with multiple medical conditions, is common and increases hypoglycemia risk. Setting appropriate goals is crucial, and the ADA continues to provide guidance on A1C and glucose targets based on comorbid conditions, functional status, and cognitive status. Table 12.1 of the guidelines can be a helpful resource to refer back to. After setting appropriate goals, simplification and de-intensification are the focus for older adults who are being overtreated. But we need to ask ourselves, when is the right time to do this? Again, the first step is setting appropriate goals. Once this is done, the ADA has provided considerations for timing of changes. A portion of Table 12.2 is pictured. This reviews the A1C goal data further described in Table 12.1. In the columns on the far right, it also indicates when simplification or de-intensification may be appropriate. Pharmacists should consider if comorbidities impact a patient's self-management abilities, if severe or recurrent hypoglycemia occurs, if there are wide glucose excursions, or if there is a change in cognitive, functional, or social situations. Additionally, pharmacists can play a special role in de-intensification in the presence of polypharmacy. In practice, this may result in reducing medication doses or discontinuing medications altogether. For individuals on complex insulin regimens that include both basal and bolus components, a specific algorithm has been developed to guide simplification. On the left, we see that basal insulin may be changed from bedtime to morning administration, and doses adjusted based on personal goals. To potentially discontinue mealtime insulin, a non-insulin agent may be added as insulin is adjusted. To the far right, we see those on premix insulin will ideally be transitioned to basal insulin with non-insulin agents. Although adding medications may appear to go against the concept of de-intensification, it can be an important change for a patient. For example, for a patient who struggles with medication adherence, it may be a great benefit to discontinue mealtime insulin in exchange for a daily pill option that can potentially be put in adherence packaging. This not only aids in consistent medication use, but it may also decrease the risk of hypoglycemia and lower treatment burden, as the patient does not need to continue to manage multiple injections. In May 2019, the Endocrine Society released a new practice guideline addressing the treatment of diabetes in older adults. This guideline addresses a variety of topics, including screening, treating hyperglycemia, treating complications, and adjusting plans for special settings and populations. As with other guidelines, there is a continued emphasis on patient-specific recommendations, especially for those with a history of cardiovascular disease or chronic kidney disease. Although we will not be going into great detail on the Endocrine Society guidelines, we will briefly review one of their resources. Table 7 addresses the use of available anti-hyperglycemic classes in patients with CKD or CVD. Renal dose adjustments and hypoglycemia risk are a major focus, but other class and agent-specific precautions are noted. For example, data regarding fracture risk and amputation with canagliflozin are included. This table may be used in conjunction with the ADA and ACE materials to quickly review key points for various medication classes. Finally, in addressing care of older adults, we will discuss the Beers list. The American Geriatric Society has updated the 2015 Beers list of potentially inappropriate medication in older adults to include 2 changes pertinent to diabetes management. Glyburide remains on the list as before, but glimepiride has also been added. Both agents should be avoided due to the risk of severe, prolonged hypoglycemia. Therefore, if a sulfonylurea must be used, glipizide may be the safest option. Sliding scale insulin was previously included, but due to confusion, additional clarification has been added. Short or rapid-acting insulin dosing, according to blood glucose levels without the additional use of basal or long-acting insulin, is not appropriate due to the risk of hypoglycemia without improvement of hyperglycemia. This applies to all settings of care, including inpatient management and long-term care. However, if a patient's insulin regimen includes a basal or long-acting insulin, the use of sliding scale may be reasonable. Both of these are considered strong recommendations for glimepiride and sliding scale insulin. Pharmacists can once again have a role by educating providers on these changes to help reduce the risk of preventable hypoglycemia. Let's go back to Mr. AB, our 73-year-old male with a history of diabetes, hypertension, heart failure, and MI who is taking metformin and glyburide. To determine his A1C goal, again, you may refer back to Table 12.1 of the ADA guidelines. Given that he has at least 3 coexisting chronic illnesses, hypertension, heart failure, and MI, An A1C goal less than 8% is appropriate for Mr. AB. Knowing that his A1C is above goal, how can we optimize his care? Per the Beers list, glyburide should be discontinued due to the hypoglycemia risk. Even if his A1C was within goal, this would be an important consideration. Although another sulfonylurea, glipizide, could be substituted as an agent that is not on the Beers list, it still carries the risks of hypoglycemia, weight gain, and has low durability. Depending on the progression of his diabetes, a sulfonylurea may offer limited glucose-lowering benefit. Instead of immediately substituting a different sulfonylurea, let's go through a stepwise approach. First, we will ask if he has a history of ASCVD, CKD, or heart failure. Although his normal renal function labs show no CKD, he does have a history of MI and heart failure. For ASCVD benefit, either a GLP-1 agonist or SGLT2 inhibitor could be used. Both classes have low hypoglycemia risk. However, due to the additional heart failure, a SGLT2 inhibitor is more strongly recommended as it can also reduce the risk of heart failure hospitalizations. Neither the ADA or ACE give greater preference to one SGLT2 inhibitor over another, so clinicians should evaluate available evidence. Renal adjustments should also be considered. Since his lab values are within normal limits, there are no concerns about renal contraindications or dose adjustments. Assessing for adequate hydration status is important to reduce the risk of volume-related adverse events with this class, especially in an older patient. For patients with heart failure, careful consideration should be made for those who may be prescribed limited fluid intake. Additionally, risk factors for lower limb amputation should be considered. Unfortunately, SGLT2 inhibitors are higher cost than his previous sulfonylurea, so the pharmacist can play a role in selecting the lowest cost agent and identifying if Mr. AB may qualify for a medication assistance program. Now we'll transition to glucose self-monitoring. When it comes to self-monitoring blood glucose, or SMBG, there are a wide range of approaches. You'll likely meet some patients who rarely or never check blood glucose. On the other hand, you may meet patients who are testing multiple times per day. How much is too much? Or how little is not enough? Per the ADA, those on intensive insulin management, meaning multiple daily injections or insulin pump therapy, should check frequently. This includes prior to meals and snacks, occasionally postprandially, at bedtime, when they suspect low blood glucose, after treating confirmed hypoglycemia until glucose returns to normal levels, and prior to exercise or other critical tasks such as driving. Clearly, this means quite frequent testing. If using basal insulin alone, there is some data to show that monitoring fasting glucose levels to inform dose adjustments can improve A1C. However, given the lack of conclusive evidence, this should still be individualized. A patient with an elevated A1C actively making adjustments to lower glucose levels may check more regularly than another individual with a stable A1C at goal who has been on a consistent basal insulin dose for some time. Again, checking in suspected or confirmed hypoglycemia is appropriate. But then the question becomes, what about the many patients on oral anti-hyperglycemic therapy or other non-insulin therapy? Although some trials have shown self-monitoring blood glucose can reduce A1C up to 0.3%, other trials have shown limited clinical benefit and question the cost effectiveness. So when can this be useful? When does it help our patients? This can be recommended for individuals who want better understanding of the impact of diet, physical activity, and medication, at any time during suspected hypoglycemia or intercurrent illness, and finally, when the A1C may not be reliable. Ultimately, self-monitoring in and of itself is not going to reduce glucose levels. If used incorrectly, it is no more than a number on a screen. If it is recommended, monitoring should be tailored to fit individual needs, and it must be incorporated into self-management and clinical plans. Additionally, pharmacists in many settings can play a role in ensuring patients receive ongoing education regarding appropriate technique to be sure that results are reliable. So that covers self-monitoring blood glucose. But what about CGM? CGM is continuous glucose monitoring, in which a small filament inserted just under the skin measures interstitial glucose. This correlates well with the typical plasma glucose measured in finger sticks. Individuals will require a sensor, which is usually applied to the skin. However, recently, the Sensonics EverSense implantable sensor was approved. A transmitter is required to transfer data from the sensor to a reader. The reader may be a separate device, a phone, or be connected to an insulin pump. You can see some of these different components pictured in this slide. While professional CGM out of a provider's office is an option, we will discuss personal CGM, in which individuals own the device that can be used on a long-term basis for at-home monitoring. Two options exist for personal CGM. With real-time CGM, continuous monitoring allows alarms for hypo and hyperglycemic episodes. Intermittent scanning, also known as flash CGM, only communicates data on demand and therefore does not have alarms. As you can see, there are a variety of CGM options on the market. These are only a few that are pictured here. Discussing details of CGM use and each device is beyond the scope of this presentation. However, due to its increasing popularity, we will discuss the Freestyle Libre system. Abbott Freestyle Libre is an intermittent scanning CGM, which is dispensed from community pharmacies. Due to its lower cost than other available CGM products, it has led to greater accessibility for patients. According to Abbott, most users with commercial insurance pay $40 to $75 per month for sensors. This product can be prescribed for people with type 1 or type 2 diabetes. So as a pharmacist, what do you need to know? First, look for 1 or 2 prescriptions. Everyone will require the sensors. However, individuals have the choice between using a prescribed reader, pictured to the left, or certain phones to scan their sensors. The individual applies the sensor themselves. No office visit is required. It is only approved for wear on the upper arm, as pictured there in the middle. After application, there is a 1-hour warm-up period before readings are available, but no finger sticks or other calibration is required. However, finger sticks may be used for confirmation when someone experiences especially high or low glucose values, and the device will prompt finger sticks as needed. The original sensor was approved to be worn for 10 days. However, there has been an update so that sensors may be worn for 14 days. Anyone using the 10-day product may contact Abbott for a replacement reader, and their provider can send a new prescription for the 14-day sensor. Since this product does not provide real-time data, the person must scan the sensor for updates on glucose, but it will show trends after scanning, as you can see pictured there to the left with the arrow that's pointing up. As with other CGM, this data is used to create a report that can be used by the individual and a healthcare team. An example report is shown to the far right. It is notable that unlike some other CGMs, acetaminophen does not interfere with accuracy. However, one potential disadvantage is the lack of alarms for individuals who want to be alerted of high or low glucose values without scanning. CGM technology certainly sounds like a wonderful option to reduce finger sticks, but when is it most appropriate? In summary, the ADA recommends real-time CGM, primarily for adults with type 1, who are not meeting glycemic targets or who are pregnant. It is also with those with hypoglycemia unawareness or frequent hypoglycemia episodes. Intermittent scanning CGM may be used to replace self-monitoring blood glucose in adults who require frequent glucose monitoring, including those with type 1 or type 2 diabetes. The ACE published a consensus statement in 2016 regarding CGM, but the 2019 guidelines for type 2 diabetes specifically acknowledge its use for those with type 2 diabetes on 3 to 4 insulin injections per day, those using insulin pumps, or those with a history of hypoglycemia unawareness or recurrent hypoglycemia. Interestingly, they state that increasing use of personal CGM is expected. With that acknowledgement, it is wise for pharmacists to become more familiar with these products, especially those dispensed from community pharmacies. Ultimately, no matter what technology is used, glucose monitoring, like all other areas of diabetes management, must be tailored to fit each individual. The need should be periodically reassessed to avoid unnecessary cost and burden to the patient. Whether monitoring is by traditional fingerstick or CGM, individuals need ongoing support. Technique should be periodically evaluated, devices should be assessed for accuracy, and individuals should be taught how to interpret results and use the data to adjust their self-management plans, whether that be by modifying food, activity, or pharmacologic therapy. Finally, clinicians should utilize this data to tailor their clinical plans for the patient. And with that, we're going to transition back to Mr. AB, and I'm going to hand it over to Dr. Olin.
Let's return to Mr. AB. Remember, Mr. AB is our 73-year-old male with type 2 diabetes, hypertension, and heart failure. He recently recovered from pneumonia and had spent a few days in the hospital. His medications now include metformin and empagliflozin that had been added to his regimen. You can see that he has some improvement in his A1C. It's now at 8.5. He's getting closer to his goal of 8. And he has a blood glucose of 150. However, today he complains of nausea and abdominal pain. What should he do? Please keep Mr. AB in mind as we go through this next segment of the presentation. Dr. Batiste discussed some benefits and new indications with the SGLT2 inhibitors. Due to their effects in improving cardiovascular disease, they now are more highly recommended, and we're going to see a lot more use of these agents. Here is a few, just to list a few drugs in the class. Us as pharmacists have to be aware that the SGLT2 inhibitors are now available in a number of combination products. So we do really have to pay attention to which patients are in fact receiving SGLT2 inhibitors. They are also being studied for type 1 diabetes in addition to type 2 diabetes, and are being used in Europe quite a bit now for type 1 diabetes, although the FDA has been a little slower to accept its use in the type 1 population. As recently, sotagliflozin has been rejected by the FDA, but in the future this may change, so we need to continue to keep an eye on it. We have been alerted to several unfolding limitations with this drug class. It will be essential for us to be aware of these complications so that we can better educate our patients to look out for them as well. The complications I'm going to focus on are euglycemic diabetic ketoacidosis and Fir Near Gangrene. We're familiar with diabetic ketoacidosis. We see it more frequently in type 1 diabetics, but it can be seen in type 2 diabetics. It's typically defined as a syndrome where somebody has high blood sugar greater than 250, has an acidosis, and has increased ketones. This could be considered a medical emergency. Euglycemic DKA, or DKA with sugars in the normal range, is rare, but it sometimes can be observed with recent insulin use or changes to insulin. Situations where there's food restriction or starvation, and sometimes this is not intentional. Alcohol use and glycogen storage disorders. Euglycemic DKA has picked up attention because there have been case reports of euglycemic DKA associated with SGLT2 inhibitors in both type 1 and type 2 diabetics. It's the lack of characteristic hyperglycemia that has delayed recognition of the problem. Goldenberg and colleagues have attempted to come up with a schematic to explain why they think this may occur. When we use SGLT2 inhibitors, they have actions at the kidney, which lead to increased glucose in the urine, because that's their mechanism of action, is helping get rid of glucose in the urine. So that results in glucosuria, and there is also a decrease in ketone clearance. This action leads to volume depletion. So we know that dehydration is a potential problem with SGLT2 inhibitors, and pharmacologically, they're helping to reduce plasma glucose. So as this plasma glucose is observed in our patients may be receiving less insulin, so reduced insulin doses or omission of insulin altogether in our type 2 diabetics. So with this decrease in insulin secretion, we then have the pancreas, which produces more glucagon. So the combination of glycosuria, decreased insulin secretion, results in an increase in glucagon, which then leads to an increase in lipolysis or breakdown in fat, and ketogenesis or production of ketones. So this combination of events, the dehydration combined with the increase in glucagon and increase in ketone production, may put an individual at further risk of ketosis or ketoacidosis. Ketogenesis may also be promoted during acute illness or known precipitants for diabetic ketoacidosis, such as prolonged exercise, changes in insulin, or reduced carbohydrates, or situations where even if somebody has a minor illness, all of these metabolic changes inside may lead to a situation where diabetic ketoacidosis occurs. Now that we know that this may happen, the FDA has recommended changes to our medication guides for SGLT2 inhibitors. Also, Goldenberg and colleagues have produced a nice algorithm or a nice plan for patient counseling that we can think about using the mnemonic STOP, S-T-O-P. The S is for stop taking SGLT2 inhibitor and seek medical attention immediately if your patient is experiencing symptoms such as nausea and vomiting, tiredness, trouble breathing, or abdominal pain. Since we don't have glucose levels to guide us, the T in STOP is to test urine ketones and glucose every 2 to 4 hours, even if blood sugar is less than 250 milligrams per deciliter. Your patient should have a plan for oral ingestion of fluid and carbohydrates, and then have a protocol in place for supplemental insulin and carbohydrates based on what the plan is based on checking ketones and glucose every 2 to 4 hours. Ideally, some kind of protocol would be best to be set for a patient and have a plan and protocol in advance for your patient taking an SGLT inhibitor that they hopefully don't have to use. Bottom line, they need to be aware to possibly check ketones if in fact they're having any of the symptoms mentioned above. The other adverse effect that has become of concern with this drug class is Fir Near Gangrene. This is a rare situation, occurs in 0.02% of all inpatient hospitalizations in the United States, and it's a necrotizing fasciitis of the perineum. While it's rare, it is life-threatening, and symptoms can progress quickly. Just the fact that your patients have diabetes is a risk factor, but we're seeing an increase in incidence with SGLT2 inhibitors. Education will be important so that we and our patients are aware of how to differentiate this syndrome from the yeast infections that we see much more commonly with SGLT2 inhibitors. A review of adverse events that were reported to the U.S. Food and Drug Administration Adverse Event Reporting System showed us that over a period of 6 years, we saw 55 cases associated with SGLT2 inhibitors, where over a span of 35 years with all other agents, 19 events reported, does show us that there is a potential increase of this event with SGLT2 inhibitors. Because we know that SGLT2 inhibitors are increasing glucose in the urine, perhaps maybe the sugary urine is a trigger for these type of events. We don't really know. But what we do know is that we need to tell our patients to seek medical attention immediately if they feel weak, tired, uncomfortable, have a new fever, and then have associated symptoms around the anus or genitals, including pain or tenderness, swelling, or erythema, which is redness around the skin. Most of the cases reported to the FDA had occurred within a few months of starting the SGLT2 inhibitor. So knowing that it's been within a few months and this adverse event of Fir Near Gangrene can occur rather quickly, so important that the patient seek medical attention immediately. What will then happen is that broad-spectrum antibiotics will be initiated and surgical debridement may be necessary. Now let's return to our patient AB, our 73-year-old male who had recently been hospitalized and recovered from pneumonia. He has metformin and a fairly recent SGLT2 inhibitor, empagliflozin, added to his regimen. Today he complains of nausea and abdominal pain. What should he do? Well, we see that his blood sugar level has been improving. It's now at 150, and we're seeing an improvement in his A1C. However, his recent hospitalization and illness with pneumonia may have led to a change in his internal counter-regulatory hormones such as cortisol and glucagon. At this point, it might be prudent for us to check his ketones and see, in fact, if he is having an issue with euglycemic DKA. So he can reach out to his provider, check his ketones, and then see what further to do if, in fact, this nausea and abdominal pain is associated with his SGLT2 inhibitor. So takeaways for this section. We've noted the proven benefits as far as improvement in cardiovascular disease, heart failure, or CKD, as well as benefits in A1C reduction and weight loss. While we've noted potential increase in euglycemic DKA and Fir Near Gangrene, us as pharmacists, if we're aware of these adverse effects and put in plans for monitoring and alert our patients for potential signs and symptoms of these adverse effects, we should be able to minimize any drug-related problems in our patients. Now the next part of this presentation will focus on updates in aspirin recommendation. There has been a lot in the news regarding who do we give aspirin to, so let's focus on what has stayed the same and what has changed with aspirin. As far as using aspirin in our patients with diabetes, what is the same or what has not changed is the use of aspirin in secondary prevention. The diabetes guidelines for 2019 recommend a dose from 75 to 162 milligrams daily is recommended for those individuals with diabetes and pre-existing cardiovascular disease. Remember, Dr. Batiste defined ASCVD earlier as acute coronary syndromes, MI, stroke, and a whole number of other cardiovascular indications. Why we use aspirin in this population is that it's been proven to reduce morbidity and mortality and proven to increase risk of a subsequent myocardial infarction, stroke, and vascular death in those high-risk patients. If patients are allergic to aspirin, clopidogrel can be used instead. All of this information has not changed. We're still using aspirin in our patients with pre-existing disease and at high risk. Where the story has changed has in those individuals with diabetes who do not have a history of cardiovascular disease. Now the guidelines are recommending low-dose baby aspirin. It may be considered only in certain cases after a discussion between the provider and the individual with diabetes. Previously, we had recommended aspirin based on what we thought the patient's level of cardiovascular risk is. However, that recommendation has been downplayed to a may be considered based on evidence from 3 large primary prevention trials that were published in 2018. 2 of those 3 trials evaluated individuals with diabetes, so I'm going to focus on those 2 trials. The primary prevention trials that included participants with diabetes were the Ascend and Aspirin trial. These participants did not have any known pre-existing cardiovascular disease, and enteric-coated aspirin of 100 milligrams daily was compared with placebo. In the Ascend trial, participants were at least 40 years old and already had diabetes. In the Aspirin trial, the main inclusion criteria was that the participants were at least 70 years old. In both trials, there was no previous cardiovascular disease, and in the Aspirin trial, participants may or may not have had diabetes. Taking a look at the patient populations and outcomes from these trials, both trials had over 15,000 patients. In the Ascend trial, in our participants with diabetes, patients were at least 40 years old and followed up for at least 7 years. We saw a benefit, a modest benefit of aspirin in terms of preventing the primary outcome, which was a composite of an MI, stroke, TIA, or death from a cardiovascular cause. There was a slight benefit of aspirin of 8.5% versus 9.6% taking placebo, who had the primary outcome. The benefit was seen within the first 5 years, but there really was no clear benefit for specific events or MI. Where when we look at the bleeding risk of aspirin versus placebo, there was a statistically significant higher rate of major bleeds of 4.1% versus 3.2%. Looking at the Aspirin trial, which was our participants older than 70 years old, 11% of these patients had diabetes, and there was a median follow-up of almost 5 years. The primary outcome of death of any cause was observed in statistically more patients with aspirin, 5.9% versus 5.2%. So taking aspirin was more likely to cause death, and most of those deaths were thought to be cancer-related, not necessarily cardiovascular. When we look at the bleeding risk, there were 8.6 versus 6.2 major hemorrhagic events in the aspirin group, which was statistically significant. So bottom line, modest to unclear benefit and harm with the Ascend trial. A SPREE trial showed harm in terms of any cause of death and bleeding harm as well. So these two big trials have really led to a less strong recommendation for using aspirin for primary prevention in diabetes. So where does this leave us? Who with diabetes can benefit with aspirin for primary prevention? What the guidelines recommend to us now is for those individuals that are age 50 to 70 years old with at least one additional risk factor for ASCVD, family history, hypertension, dyslipidemia, smoking, CKD, or albuminuria. So we can look at these individuals who have a risk factor, but we also have to account for that they also have a low risk for bleeding. How do we assess who has a low risk for bleeding? Well, we have to look at people who don't have a bleeding history, who don't have alcoholism, who are not at an older age, who are not taking concurrent NSAIDs or steroids or anticoagulants, who do not have bleeding disorders or hematologic disorders such as anemia or thrombocytopenia. So this is going to really probably exclude a lot of our patients, but if we've ascertained that somebody has a low risk for bleeding by not having any of these other disorders and that they do have risk for ASCVD, the guideline, it's now suggested to us that we can have a discussion with our patient to see if they think that they may benefit from using aspirin for primary prevention. Now let's do a self-assessment, thinking about what we just talked about with use of aspirin in individuals with diabetes. Take a minute to think about which of these individuals with diabetes should aspirin therapy be considered. We have a 74-year-old with chronic obstructive pulmonary disease and diabetes. We would be thinking about aspirin for primary prevention. We've learned now from the clinical trials that there is no benefit and possibly harm in using aspirin in individuals over age 70. So a 74-year-old with chronic obstructive pulmonary disease would not be recommended aspirin for primary prevention. Our second patient is a 55-year-old with diabetes and peptic ulcer disease. While this individual does fit in the window for somebody in whom we might want to review his cardiovascular risk factors, the fact that he has peptic ulcer disease may put him at a higher risk for bleeding. So we probably would not want to institute aspirin for the 55-year-old. A 45-year-old with peripheral vascular disease. A 45-year-old does fit into our age window for assessing whether they would benefit from primary prevention. However, peripheral vascular disease is one of those conditions that compromises ASCVD. So the 45-year-old, we would be recommending aspirin to, because in that context, it would be used as secondary prevention for their peripheral vascular disease. In fact, aspirin may be offering more benefit than harm for that individual. A 63-year-old with hypertension. fits into the window for whom the guidelines are discussing. Hypertension may put that patient at higher risk for clinical ASCVD. If we decide that the 63-year-old is at low risk for bleeding, patient number 4 is somebody in whom we may want to consider aspirin for primary prevention. Finally, our patient AB, who was our 73-year-old with our 73-year-old male with type 2 diabetes and hypertension and a past medical history of MI. Our patient AB is somebody in whom aspirin therapy would be secondary prevention, so he would not fall into the window of considerations for primary prevention. I hope this self-assessment gave you a little bit of an idea of the thought process behind whom we do consider aspirin for and who we don't consider aspirin for. This brings us to the end of our program. We hope by listening to this webinar that you as pharmacists, no matter what practice setting you're in, that you should be able to identify potential medication optimization opportunities based on updates to the major guidelines for diabetes. We talked about some ways that you can assess older patients for overtreatment and consider simplification and de-intensification as appropriate. Dr. Batiste covered ways to identify potential over or underutilization of glucose self-monitoring and ways to educate your patients on continuous glucose monitoring devices dispensed from community pharmacies. We also talked about the signs and symptoms of newer potential SGLT2 inhibitor-related adverse effects, including euglycemic DKA and Fir Near Gangrene. And we also hope that you'll be able to discuss the risk and benefit of aspirin for primary prevention so that you can make sure that it is appropriately being used or not used in your patients with type 2 diabetes. We hope that you appreciated an opportunity. Thank you. We have enjoyed providing this webinar for the North Carolina Association of Pharmacists, and we hope you found this information to be useful and helpful. For you to receive your continuing education credit, please follow the instructions provided alongside this webinar's link on the MCAT website. Thank you again for your attention.